And he has also been the chair of a lot of working groups, and both in IFCC, EFLM, and also in clinical societies. And he is also very well known as the editor-in-chief of clinical chemistry and laboratory medicine. And you're going to talk about performance specifications in the extra-analytical phases.
Thank you, Mr. President. Thank you for the organizers for kindly inviting me, and even thank to Mauro Panteghini for enrolling me in the working group at the time. So, the first slide is just to say you that the time they are changing, as in the famous song by Bob Dylan, and substantial changes in the landscape of laboratory medicine, in fact, did happen in the last 50 years. And we can recognize that the quality 50 years ago is very different from the quality we have to deal with today. And therefore, the increasingly important role of laboratory information, and not only of analytical results in the medical decision-making process, has led to the need for a greater focus on the total quality and safety of laboratory service. There is a noise. Please. Sorry. So the focal point of the concept of quality in laboratory medicine is shifting from internal processes that mean not only but particularly analytical quality to the impact of laboratory information on patient care and on assuring a healthy status to any individual, or better, the entire population. And as stated in the way, quality in laboratory medicine should therefore be defined as a guarantee that each and every step in the total testing process is correctly performed, and therefore, only in this way is possible to ensure valuable decision-making and effective patient care. So the main drivers of the paradigmatic change of the landscape of laboratory medicine, from one side, is the evidence of the vulnerability of the extra-analytical phases. This is for sure. And from another side, the increased recognition of the need for a focus on the added value of laboratory information in improving the decision-making process and clinical outcomes. So we know that this is a meta-analysis putting together the data we have on the state-of-the-art of errors, and as you can see, pre- and post-analytical phase are much more vulnerable to errors. But I like to stress this point. Quality in the analytical phase is not for sure, and we have to strive to improve the analytical quality day by day. So the message is clear. The magnitude of errors in pre and post is bigger, but even the analytical phase should be maintained and improved every day. So the other is not only analytical result, but what counts is laboratory information. We know for sure this. And this was in the famous brain-to-brain loop seminal theory by George Lundberg, released in 1981. But what is not well known is the importance of the interrelationship between the different phases of the brain-to-brain loop, and in particular, the interdependence between the pre-analytical phase and the analytical phase, and the role of post-analytical steps in affecting the quality of the final laboratory information we are providing every day. So this means that good samples make good assay, not only the methods. And therefore, in the pre-analytical phase, the 5 rights are right patient, right time, right test, right sample collection, handling, and right sample transportation. In the pre-analytical, it's necessary to provide high quality of the specimen to the specimen, and the 5 rights are the right separation, pre-treatment, aliquoting, saltation, routing, and only in this way we can achieve a good analytical quality. Therefore, a good method in bad samples doesn't work. So not only, but when you have a good analytical quality, only if there is a good post-analytical quality, it's possible to provide a good laboratory information. The 5 rights are right turnaround time, right data validation, right units, right reference range and decision limits, and the right critical values communication and eventually interpretative comments. And finally, in the post-analytical phase, we have to provide the 5 right acknowledgement by the clinician, nurses, right interpretation, right utilization, right follow-up, right documentation. This should be assured only by a close cooperation between the lab and the clinician world. So what about the pre-analytical quality? The uniqueness of the pre-analytical phase is it can influence all the subsequent phases, thus making it a critical step. So without quality in the pre-analytical, all other phases are without quality. And therefore, pre-analytical variables are factors in handling that affect the integrity of biospecimen and later on the results of the analysis. And pre-analytical variables may introduce in vitro modification, either systematically or randomly, that adversely affect the results. And when the result of a test deviates from the expected, the analytical integrity of the data should be questioned rather than only the pre-analytical integrity of the sample. Today we are doing with this. So, what about the post-analytical quality? It has been stressed that the accurate and timely reporting of laboratory tests, particularly those with critical values, is much important, is very important, at least as important a quality requirement as their proper execution. So, this is a typical case of dramatic post-analytical error. That is a transcription error described in JAMA last year. As you can see, the result was 0.06 millimole per liter. It was an accurate result, but it was transcribed as 6.0. And this translated in harm for the patient, because this patient, the lady, was submitted to a hemodialytic treatment. So today we know that we have to avoid mostly TITANIC errors, and TITANIC error usually may happen in the pre- and post-analytical phases. Going to the analytical quality, the dramatic and impressive reduction, at least 300-fold, of the analytical errors in the last decades emerged was due to the widespread introduction of automation, information technology, improved laboratory technologies, assay standardization, better training for laboratory professionals. But I would like to point out that the availability of well-defined rules, indicators for internal quality control, as well as effective quality assurance schemes, did play a major role in improving analytical quality. And this is what happens for a cholesterol moving from 1969 to today. This is the data of our external quality assurance in Italy, and you can appreciate the decrease in the error rates in percentage. So, why we were able to manage a so dramatic improvement in the analytical quality? Because the goal was analytical, well-setted analytical performance specification in terms of biased imprecision. The tools were and are internal quality control and external quality assurance or proficiency testing for the American. And finally, the indicators were intra- and inter-laboratory comparative performances. And this made possible the improvement. So the question is why we have to apply quality specification only and quality indicator only for the intra-analytical phase. Oh, this is so it's very important, yes, but up to now, it failed, or up to some years ago, it failed, the idea. So this is again the famous EFLM strategic conference. I will be very facilitated by the presentation by previous speaker, in particular this morning, by outstanding presentation by Mauro Panteghini. So the question is that in Milan, this is the hierarchy of models for setting quality specification in 1999 in the Stockholm conference. And this is the revised version, very, very facilitated for your appreciation. So this is a work already you know, because it was provided this slide even by Professor Panteghini. And we are working at the task finish group on performance specification for the extra-analytical phases. So in principle, the performance specification for extra-analytical phases should follow the same model as for the analytical performance specification. But unfortunately, there are no data in the literature on extra-analytical performance specification based on biological variability. Of course, there is no biological variability in the extra-analytical phase, no measurable. Neither for outcomes or beta. The unique data is that some errors in the pre-analytical, particularly, should be totally avoided. For instance, patient sample identification and data transcription. So the performance specification is zero defect. And we had few data on the clinician opinion, no data on the clinician opinion, while the collection of data on the state of the art based on quality indicator is ongoing. So we had to cancel the model based on biological variation to set the performance specification in extra-analytical phase, and unfortunately, up to now, we have few data about the outcome. So, we are moving to the story of quality indicators, and therefore, you can here recognize the difference between the performance specification in the analytical and in the extra-analytical phase. So, why the story of quality indicator? Because quality indicators are useful not only to identify and document the errors, but to make possible corrective and preventive action in the total testing process. And the story is that the true rationale of quality indicator is by Edward Deming, a father of quality, is that you cannot manage what you cannot measure. So you have to measure. And healthcare quality indicators in general provide an important tools for measuring the quality of care, even not only in the laboratory medicine, because they are based on evidence of best practice, and we have many, many data in the literature demonstrating the usefulness of quality indicators in general. So we cannot assess improvement in what we cannot measure, and quality indicators represent the starting point for programs aiming to improve quality in the total testing cycle, particularly in extra-analytical phases, and in patient safety. So we are starting from here, and we launched in 2009 this program under the umbrella of the IFCC I will deal with. Which type of quality indicator? We have two types, process measurement, and we need harmonization, metrics, and performance specification. And we are dealing even with outcome measures. The work is in progress, but we have data even with this type of indicators. So take a note that it is very important to use quality indicator. And according to the International Standard for Laboratory Accreditation, for receiving accreditation, implementing quality indicator is a must. So you need to have quality indicators. And this is very clear in the requirement. And which type of quality indicator? Not only in the analytical phase, but also in pre-examination, examination, and post-examination processes. That means intra and extra-analytical phases. So what about the criteria for harmonizing quality indicator? We define and we find three criteria: They should be patient-centered. They should be consistent with the requirement of the international standard for medical laboratories accreditation, that is the ISO 15189, particularly the last release. And finally, they have to address all stages of the total testing process as required by the definition of laboratory errors that is in this ISO technical standard 22367 released in 2008. So this is the website, and you can go to the website to have more and more information about the project. And eventually, you can ask for receiving a password, and you can enter the data collected in your lab. You can do the benchmark against many laboratories around the world. But why we have decided to harmonize quality indicator? Because there are many programs around the world. And so harmonization is very important, because if a single laboratory and all laboratories around the world use very different and not harmonized quality indicators, quality improvement in-house is possible, but benchmark is not possible. So quality, the harmonization is based on a harmonized set of quality indicators, but even on a harmonized reporting system. And this makes possible to compare the result of different labs around the world, to identify the true state of the art, and finally to define quality specification, performance specification for each quality indicator. So this is the rationale, and we had the first harmonization quality control consensus conference in 2013 in Padova. And we published this paper 1 year after on the consensus. You can have by downloading for free this paper. We have identified 25 indicators and 53 measurements. As you can see, key process, there are 11 pre-analytical indicators in the pre-analytical phase, 4 in the intra, and 5 in the post-analytical, and we have even 2 outcome measure and 3 support processes. So we established a priority. So possibly rank 1 means that more or less these are mandatory, are very, very important. The other for best in class. And this is what we published, the key process quality indicator with the priority first, 1, and you can deal with them, but you have many papers for reading better and better this slide. The model of quality indication up to now was followed by more than more or less 200, more or less 300 laboratories around the world from many, many countries, not only Italy, of course, not only Europe, but outside in Brazil, Argentina, United Kingdom, that is in no more in the Europe, India, and so on, in China. This is the typical statistical treatment of the data and the reporting all labs should receive, in which you can see not only the result, but the trend over time, the frequency of distribution. But we have decided to have another consensus conference, and 2 years later, we organized another consensus conference. And this was 1 year ago, and the discussion was an update of the current list of quality indicators. The problem of automated versus manual data collection, this is a problem, but we are working on. The statistical treatment of the data to have sound results, the criteria for the definition of quality specification. And therefore, the consensus statement received was that we have now 26 indicators. As you can see, there are only 11 in the pre-analytical. We delete some indicators. We have 5 in the intra-analytical, 4 in the post-analytical, and 3 outcome measures. And again, as you can see, the priority, or this means mandatory more or less, are 19 in the pre-analytical, 6 in the intra, and 9 in the post-analytical phase. So this is an example, Haemolyzed sample. you can see what happens. We have the definition of what is hemolysis was achieved the consensus on this, and you can see the data collected over time. It's very interesting what happens in a lab. This is my lab, moving from visual detection to automated serum index. An increase in the error rate, but after some corrective action, as you can see, this is managed. But this was the true percentage of errors. And this is not in percentage, but in sigma, in the so-called sigma score. So only by using harmonized quality indicator and the standardized reporting system can we document the state of the art and define current performance specification. And the proposal was to follow more or less what was done by Fraser to classify to set the quality specification for intra-analytical, for the intra-analytical phase. So the famous 3-level, minimum, desirable, optimum. But we described this as low, medium, and high, because it's not desirable in the next analytical phase. So in this paper, you can appreciate, for instance, the quality indicators and the quality specification. Provisional quality specification, as you can see, is defined as low, medium, and high. And what the lab should do is to move from the low level to the medium, or at least better to the high level. So reducing the errors and improving the performance criteria. And as you can see, for other quality indicators, you can see as eventually all other proposal up to now performance specification based on 75, 50, and 25 percentile, describing the low, medium, and high level of performance. So this is very clear, the proposal, but we are moving towards the state of describing the state of the art. As you have medium, but we would like to strive to have high performance, and this means to stay into the 25 percentile. But it's educational work we are doing. So this is even the quality specification in general in the pre-analytical, intra-analytical, and post-analytical phase. According to the EFLM task finish group, we delivered a survey to at least 1,000 labs around the world. We received many answers, and therefore we can deal with, we publish a report. The problem today is that many labs underline the problem of the lack of an information system to support that data collection. Some are using quality indicator developed in-house, not harmonized. And as you can see, only 52% were aware of the model quality indicator. So I assume that today many labs should be confident with the program. And the problem is that the top 10 most adopted quality indicators are Haemolyzed samples, misidentification errors, incorrect sample, but other quality indicators are not followed up to now. And the majority of respondents believe that the performance criteria for extra-analytical phase should be derived from the quality indicator. But another 35% of respondents did not answer, so there is no idea what they are thinking about. So today, we can describe the story of the quality indicator as a paradox, because from one side, there is an increasing interest, there is another available list of harmonized quality indicators, and a specifically developed website you can do for free. So, good. But from another side, few laboratories around the world are collecting regular and comprehensive data. So I like to stimulate more and more labs to do this. We have many papers published. Most of them are downloaded for free. And we have many papers published also on the performance specification in the extra-analytical phases, provisional performance specification. So we need to cooperate with more and more labs around the world to provide more robust data on the performance specification and to identify the goals for improvement around the world. So the take-home message are, the last 50 years have seen substantial changes in the landscape of laboratory medicine. And the concept of quality of laboratory services, therefore, is changing. The main drivers of the change are the evidence that extra-analytical phases are much more vulnerable than the intra-analytical phase, but believe that I'm the father of this theory. I invite you and recommend you to improve every day the quality of the analytical phase. It's the magnitude of errors that change. The development and the utilization of analytical quality indicators based on widely accepted hierarchy of performance criteria and well-known tools, internal quality control and external quality assurance, did play a major role in reducing the analytical error rates in the last 20, 30 years. And therefore, the development and utilization of quality indicators in the extra-analytical phase is still in its infancy, but it is working and seems to work well if many other labs are enrolled in the program. So extra-analytical quality indicators represent a valuable tool for identifying, documenting, reducing error in the total testing process. Harmonized quality indicator, only harmonized quality indicator may allow improvement in in-house quality, but also should work as a benchmark with other laboratories at the international level, should play a role in external quality assurance in the next few years. So quality indicator allows the identification setting of performance criteria for the extra-analytical phase of laboratory testing. I hope to have convinced you of these findings. So, yesterday, the paradigm was analytical quality management by the right utilization of internal quality control, external quality assurance schemes, based on valuable setting of analytical performance specifications. Great work done. Today, total sample management through the use of quality indicators in the intra and extra-analytical phases and intra and extra-analytical performance specification, we have to work to provide more and more robust data, but we have started to work on this. But finally, tomorrow, I believe that we have to move toward the total patient information management using outcome indicators. Thank you very much for your attention.
Thank you very much. I have two questions or commands for you. The one thing is about crossing over